So speaking of autoimmune liver diseases, I have the great delight of introducing Dr. Michele Tana here today. She grew up in Northern Virginia and initially studied classics at Harvard then before attending Harvard Medical School. She then trained in internal medicine at Stanford University and clinics in internal medicine, and then gastroenterology at California Pacific Medical Center. She was then a hepatology fellow at the NIH and NIDDK, and earned a master's degree in clinical research from Duke University, which we can see the fruits of here at the General. She first joined our UCSF faculty in 2013, where she serves the vulnerable patient population at the General and teaches UCSF students and trainees. She's a huge help to our department by directing the gastroenterology rotation for the surgery residents and serves as the Hep C consultant for the National Clinician Consultation Center. In 2018, she helped launch the prospective observational study to understand liver diseases. And her team collaborates with researchers across disciplines and across the globe to apply state-of-the-art science and technology to liver disease with a focus on equity in autoimmune hepatitis, which we have even seen in our clinic as recently as yesterday. I personally have enjoyed working with Dr. Tana multiple times in patient and in clinic, and I've not only learned from her gentle and compassionate approach to patients, but I appreciate that she always encourages trainees to keep even the minutia and the goals of our week at top of mind, so we can contextualize our short-term learning with our long-term goals. So thanks to Dr. Tana for that, and thank you in advance for this talk.
All right, thank you, Molly, for that kind introduction. I'm really honored to be giving grand rounds today, so thank you all for attending. Here's an outline of what we'll be covering. First, we'll do an overview of autoimmune hepatitis, touching on epidemiology, diagnosis, and prognosis. Then we will have a section about therapy for autoimmune hepatitis, first line and beyond. If there's time, we'll have a short break and then come back to talk about other notable advances in the field and finish with talking about some of the research that we've been involved in at UCSF and opportunities for collaboration. So many of you may think of autoimmune hepatitis as a rare disease, which it is. However, epidemiologic studies have shown that it is increasing in incidence and prevalence. So some estimates of incidence are 1 to 2 cases per 100,000 persons per year, point prevalence 11 to 17 cases per 100,000 persons per year. Many of these statistics have come from Europe, and much higher rates of AIH have been reported in populations such as Alaskan Natives, also the indigenous populations of Canada. Like many autoimmune diseases, AIH does predominantly affect women in a ratio of 3.6 to 1 women to men. It has long been known to affect all ethnic groups and racial groups, and people of all ages, with a peak incidence in young women. However, recent studies have also shown a second peak amongst older women. So overall, AIH is increasing worldwide with a prevalence that's been increasing up to 50% over the last decade. And this is a graph from an article published by Lambda et al. From New Zealand showing a rise in AIH compared to PSC and PBC. The group out of University of Pennsylvania has published some additional articles about AIH epidemiology in the United States. They have made use of an administrative database called the Optum database, and they focused on patients who were diagnosed with AIH and cirrhosis simultaneously. And they looked for patients who had those codes for the first time contemporaneously. And what they found was that this incident AIH with cirrhosis was significantly associated with male sex, Black race, and Latinx ethnicity. And this foreshadows some of the research that our group has done. Furthermore, they looked at the incidence of AIH by ethnic group within the United States. And you can see that depicted here. So AIH A shows that amongst white Americans, the incidence of AIH is highest in the mountain region, and that amongst Black Americans, the incidence of AIH is highest around the Great Lakes. Amongst Latinx Americans, incidence is highest in the Southeast and Southwest, and then amongst Asian Americans, also sort of the South. In terms of clinical presentation, AIH can have a wide variety of manifestations. The most typical presentation is someone with abnormal aminotransferases and hypergammaglobulinemia. And then you can have one or more of the following. So again, an asymptomatic person is quite typical, but patients can also have symptoms of fatigue, malaise, and arthralgia. Those, I would say, are some of the most common symptoms. Or patients can present more acutely with hepatitis, fulminant hepatic failure, or acute liver failure, cirrhosis, or decompensated cirrhosis. Quality of life has recently become more apparent as an important part of the experience that people with AIH have. This was a study based out of the Autoimmune Hepatitis Association, which is a national and international patient organization. They did focus groups with patients who have AIH and found that many symptoms are overlooked by the medical establishment, but negatively impact quality of life. So again, things like fatigue, brain fog, sleep disturbance, anxiety, and depression. These were very common amongst our AIH patients. This is a diagnostic algorithm we can use to think about the workup for a patient with AIH. So again, abnormal transaminase levels, a common reason for consult in the hepatology clinic. You want to check autoantibodies and serum IgG level. If they're normal or negative, you can go on to check a second round of autoantibodies. But if they're elevated or positive, and you don't have another explanation for abnormal transaminases, you might proceed to a liver biopsy. And then autoimmune hepatitis has particular diagnostic criteria, including things like interface hepatitis, which we'll get into more in the next slides. Once you have a diagnosis of AIH, typically we start corticosteroids for therapy, and then the response to therapy can help confirm the diagnosis. Alternatively, if the autoantibody workup, both the first round and second round of testing, are negative, maybe you would continue to observe the patient. And then if, say, 3 months later, the transaminases are still elevated, reconsider your diagnosis, think about obtaining a biopsy then if there's still no other considerations. So this is a slide of typical histopathology you might find if you biopsy a patient with autoimmune hepatitis. This is the Masson's trichrome stain showing fibrosis in purple. And this patient has early bridge formation starting in the portal areas. Here you can see a lot of inflammation, kind of a dense lymphoplasmacytic infiltrate around the portal tract, but also spilling into that interface area at the intersection of the portal and lobular areas of the liver. And then also in this patient, you can see acidophils, which indicate hepatic necrosis. And then this is a close-up of plasma cells in the dense inflammatory infiltrate in a patient with autoimmune hepatitis. Oops. Okay. And because the diagnosis of AIH can be challenging, the International Autoimmune Hepatitis Group has developed and published several scoring systems. And this is one from 2008 called the Simplified Diagnostic Criteria. And you can see that for different values of autoantibodies and different levels of IgG elevation, points are assigned. Also based on the liver biopsy findings, if they're compatible versus typical with AIH, patients get 1 or 2 points. And then the absence of viral hepatitis also adds 2 points. So a total score of 6 or higher indicates probable AIH, 7 or higher indicates definite AIH. And this is useful clinically, but also for research studies. More recently, an international group of AIH pathology experts did a modified Delphi consensus and came up with a consensus statement that was published in Liver International in 2022 on the histopathologic criteria for an AIH diagnosis. And they came up with this somewhat helpful but a little bit complex algorithm where they said that most patients with AIH have a predominantly portal lymphoplasmacytic infiltrate, which is depicted here. And then they may have more than mild interface, depicted by the sort of star-shaped extensions here, more than mild lobular inflammation. You could see inflammation in the lobular areas. Or they could have more than mild lobular and more than mild interface hepatitis, which is depicted here. Then you want to ask if there are features of another liver disease on the biopsy. And then based on those answers, you can say that the patient either likely has AIH, possibly has AIH, or is unlikely to have AIH. And then they similarly have a part of the algorithm for patients with a predominantly lobular hepatitis. So if the patient's inflammation is mostly in the lobular areas and they have at least one of the following, so portal lymphoplasmacytic hepatitis, interface hepatitis, or portal-based fibrosis, the next step is to again ask if they have features of another liver disease, such as MASLD, which we see commonly, and then that will help you decide how likely they are to have AIH. That group of experts also decided that they did not think emperipolesis or rosettes were specific for AIH. And those are other histopathologic findings that have traditionally been associated with AIH biopsies. So now talking about prognosis in patients with AIH, cirrhosis has been found in many studies to be a major predictor of poor survival and need for transplantation. This is a study from Germany, including over 300 patients followed for over 10 years, and showed that cirrhosis was associated with poor survival and need for transplantation. You can see in green the patients with cirrhosis and in blue the patients without cirrhosis at diagnosis. In addition, initial treatment response has been associated with survival and is a prognostic factor in AIH. This is a study from Scandinavia with including over 450 patients, and they defined complete remission as a normal ALT within 1 year. Partial remission is shown here in green, and was defined as an ALT less than 5 times the upper limit of normal at 1 year. And you can see that the patients with no response to initial therapy had much worse survival. Histologic remission has also been linked to outcomes in AIH. So in this study published in 2019, you can see that patients with an Ishak histologic activity index of 3 or less are shown in blue, and those patients did better than patients with more inflammatory activity on their repeat biopsy in terms of all-cause death, liver-related death and transplantation. And then finally, race has been shown to be associated with outcomes in AIH in multiple studies. This is an earlier study from 2007 out of Johns Hopkins by Verma et al. And you can see here in this survival curve, Black patients in green and the non-Black patients in blue. They were looking at a composite outcome of liver failure at presentation, failure to achieve remission, need for transplantation, and death. And there was a significant difference on the basis of race. Okay, now we'll transition to talking about therapy for AIH. There are several pretreatment considerations to remember. So some of these are related to what we refer to as healthcare maintenance. So making sure that the patient is up to date with vaccinations, including hepatitis A and B, COVID, flu. And then also prior to initiating therapy, you want to assess for the safety of using our main maintenance therapy, azathioprine, by checking the TPMT activity level. Another thing to consider, which may come up, is the risk of hepatitis B reactivation. So hepatitis B serologies should be sent prior to initiating therapy, particularly if you're planning to use high-dose corticosteroids. And then bone health is a concern for our patients with autoimmune liver diseases and metabolic syndrome as well. It's extremely common in the population, but because we're using immunosuppressive therapy like corticosteroids, we have to also be particularly cognizant of the patient's metabolic profile. And then family planning is something that should be top of mind because many of our patients are women and a lot of them are of reproductive age. So ideally, they are in complete remission from their autoimmune hepatitis for a year before conception. So that requires a lot of communication and advanced planning for our young female patients. You can also see here that mycophenolate is contraindicated in in pregnancy, and that prednisone and azathioprine are thought to be safe and should typically be continued in pregnancy. So first-line therapy for AIH can be broken into induction therapy and maintenance therapy. Induction therapy consists of corticosteroids, and our options are budesonide, prednisone, or prednisolone. We'll see a little bit more about budesonide on upcoming slides, but it should not be used in patients with cirrhosis. Maintenance therapy has typically been azathioprine. And again, before starting azathioprine, one should check the patient's thiopurine methyltransferase activity because azathioprine can cause bone marrow suppression in patients with low enzyme activity levels. And then the dosing of azathioprine is variable. We'll talk about that on the next slide as well. And azathioprine metabolism can be monitored through the use of thiopurine metabolites. So this is a slide about induction therapy with some samples of how one might start treating a newly diagnosed patient with AIH. So one option is monotherapy with prednisone. And then you can see here a typical taper structure. And you might consider monotherapy without a maintenance medication if the patient already has cytopenias, because as we talked about, azathioprine can cause bone marrow suppression. If their TPMT activity level is low, you wouldn't want to use azathioprine. If they are pregnant, maybe you're thinking that you want to avoid some of the other medications during pregnancy, malignancy, or if you're expecting the therapy to be short in duration, there are some experts who prefer just to use the corticosteroid. But I would say in most cases, we go for combination therapy. So that's usually a steroid plus azathioprine. And then again, our options here, different dosing strategies over the first several weeks of therapy. And then the dosing for azathioprine is typically 50 milligrams per day, according to American guidelines, but 1 to 2 milligrams per kilogram per day, according to European guidelines. And the benefit of combination therapy is that we can typically more successfully wean the steroid dose. And you would want to do that if the patient is at higher risk for complications from steroids, and really who isn't. So anyone at risk for osteoporosis, uncontrolled diabetes, hypertension, obesity, so all those metabolic factors we talked about, acne or emotional lability. And then here's one of the major sort of landmark papers about budesonide. It came out in Gastroenterology in 2010, again from the German group in Hanover, showing that budesonide in a head-to-head trial with prednisone achieved normalization of transaminases in a greater proportion of patients. And you can see here the intention to treat analysis, the per protocol analysis, looking for normalization of the transaminases within 6 months versus less than 2 times the upper limit of normal at 6 months. And so budesonide kind of came into the limelight after this paper in 2010, and we still use it a good amount. And the main advantage is that you have less systemic symptoms or adverse effects from the corticosteroid because of first pass hepatic metabolism. This is a diagram showing the progression of management in AIH, starting with those pre-treatment considerations we talked about, and then having the patient, we're profiling the patient as someone without cirrhosis, with cirrhosis, or with an acute severe presentation. That will dictate your choices for induction therapy, which medications you choose or cannot use. Because again, you can't use budesonide in cases of acute severe AIH or cirrhosis. And then, also the consideration of transplant for those patients with decompensated cirrhosis or acute liver failure. And then we move into the maintenance therapy phase. But oftentimes problems arise. And that can be anything from intolerance of the drug to inadequate response. And then here we see potential maneuvers. So you can check those thiopurine metabolites, adjust the dose, check the patient's adherence. That's a common problem because the medications have so many side effects. Think about within class switches. So that might be trying 6-MP instead of azathioprine. And then again, if the patient's flaring, you want to make sure you exclude alternate diagnoses or other processes that might be happening at the same time as an AIH flare. And then you might need to escalate therapy. So here we have MMF, mycophenolate mofetil, as our second-line therapy. And then if that's not working either, other potential maneuvers are to consider a repeat liver biopsy, think about a research study or trial, consultation with experts, and then third-line therapy is listed here. So this was an exciting study that came out of Europe. So it was mostly centers in the Netherlands, but also Germany. It was published last year in the Journal of Hepatology and was a randomized controlled trial looking at azathioprine versus mycophenolate for induction therapy of newly diagnosed AIH. And they also used prednisolone in a tapering fashion. So you can see here, the patients, the centers, it was a 6-month trial. Here's the intervention. You either get azathioprine or MMF. Their primary outcome was the percent of patients with normalization of the ALT and IgG at 6 months. And what they found was that the MMF group had a higher percentage of patients meeting that primary outcome. So 56% of the MMF group versus 30% of the azathioprine group had normalization of ALT and IgG at 6 months. And then in terms of secondary outcomes, adverse events were more common in the azathioprine group. So here we may be seeing a paradigm shift in the therapy for autoimmune hepatitis. And with more studies, we may find that MMF moves into that first-line therapy option. However, one thing to remember is that MMF is contraindicated in pregnancy. And again, we have a lot of patients with AIH who are women of childbearing age. So that is a caveat. And for that reason, azathioprine may remain our first line go-to therapy. So this is a table from a review article that Irina Dow, Ariel Klepper, and I wrote about second and third line therapies for autoimmune hepatitis. And it goes over different studies of mycophenolate, tacrolimus, cyclosporin, sirolimus, infliximab, BAFF inhibitors, rituximab, and methotrexate. Overall, though, many of the studies are small, and many of these drugs only have a few studies supporting their use in AIH. This is a slide about mycophenolate, which is the most commonly used second-line therapy for AIH. It's generally well tolerated, with the exception of cytopenias in the case of certain patients, as well as GI intolerance is fairly common. So we can think about the efficacy of mycophenolate in AIH in two groups. So amongst the patients who had insufficient inadequate response to azathioprine, about a third of them will achieve a biochemical remission with mycophenolate. Contrarily, in patients who were intolerant of azathioprine because of side effects, the biochemical remission rate is much higher with mycophenolate at 60 to 90%. And that is a general theme in escalating therapy for AIH. You will see better results for patients who were merely intolerant to the first attempts at therapy. And you'll see sort of lower response rates amongst people who didn't respond well to the first agents that were tried. Tacrolimus is another medication used sometimes as third-line therapy for AIH. No specific trough target has been established, but range from 1 to 10 nanograms per milliliter. There are potential side effects like neurotoxicity, nephrotoxicity, and hair loss. And then again, the response rate ranges from 57% remission rates in people who had an insufficient response to azathioprine to 94% remission rates in patients who were intolerant to azathioprine. This is a recent article from the Spanish group called the COLHI Registry. And so that's a multi-center registry of patients in Spain. The Data Coordinating Center is in Barcelona. They published about the use of rituximab in autoimmune hepatitis. And what they found was that it is safe and effective in AIH. And in this case series of 35 patients, some of the patients had refractory AIH, and others were on rituximab because of a concomitant autoimmune disorder. they saw a complete biochemical response rate with normalization of AST, ALT, and IgG at 6 months of 86% in those with refractory AIH and 90% in those with who were on rituximab for other autoimmune disorders. And then there were a handful of adverse events. One person experienced anaphylaxis, 2 flu-like symptoms, and there were 5 infections. But several of the patients were able to discontinue their other immunosuppressive medications or reduce the dose of their other immunosuppressive medications. Could anti-TNF therapy be used instead of corticosteroids for AIH therapy? This is a small randomized trial from Germany. This is from the Hamburg group, where they had, I believe, 12 treatment-naive patients who received infliximab at 5 milligrams per kilogram, and then 24 patients who received the standard of care. And you can see here that both groups experienced a nice decrease in their transaminases. The infliximab group had a smaller decrease in their IgG levels. And they also, as part of this study, had done translational work on liver biopsies, showing enrichment of the TNF pathway targeted by infliximab. And this is unpublished work, but provided very courteously by Jan-Philippe Welsh at UKE. Next, we can talk a little bit about the withdrawal of therapy in AIH. So this is an area of controversy, but it's generally thought that after 2 years of well-controlled disease, one can consider withdrawing AIH therapy. And there have been studies showing that even within the normal range of transaminases and IgG, the lower the better before withdrawing therapy. So you can see here in this table that the lower ALT and IgG at withdrawal was associated with a lower risk of relapse after the drug was stopped. And repeat liver biopsy is recommended prior to withdrawal of therapy, but according to the latest guidance, is not mandatory. And again, one would be looking for that Ishak histologic activity index of 3 or less, being minimal inflammation and indicating that it would be okay to attempt withdrawal. But you would have to monitor the patient very closely for relapse because according to certain papers, like this one out of the Netherlands, relapse of AIH is almost universal after stopping maintenance therapy. All right, so now I think we'll take a little break and we'll come back at 8:40 to wrap it up. Go ahead and stretch your legs. I'll be back. All right, guys, I hope that you're ready to finish strong. 20 more minutes.
Welcome back. Looks great.
Okay, great. Um, so now we'll go on with some recent advances in the field. Clinical endpoints in AIH have long been debated, and in 2022, there was an article published in JHEP. This was a collaboration through the International Autoimmune Hepatitis Group. They performed a systematic review and Delphi consensus and determined expert proposed and advocated endpoints to use in both clinical care and studies about AIH. So they defined non-response as a less than 50% decrease in transaminases after 4 weeks of initial therapy. They also proposed a definition of complete biochemical response as normal transaminases and IgG. So that's AST, ALT, and IgG within the local lab's normal range after 6 months of therapy. Conversely, without achieving those parameters, that would be called an insufficient response. They defined intolerance to treatment as any adverse event possibly related to treatment assessed by the treating physician, leading to potential discontinuation of the drug. And then they, after debating different definitions, they settled on remission as being a histologic diagnosis obtained on a repeat biopsy. Again, with that HAI score less than 4 out of a total possible 18 points. So here comes our friend budesonide again. This was a paper from the Spanish Colhai group, published in JHEP in 2022, showing that budesonide is inferior to prednisone or prednisolone for induction therapy of AIH. They were looking at biochemical response during follow-up. They also looked at 6 months and 12 months and found that the proportion of patients with response was significantly lower amongst the patients receiving budesonide compared to prednisone. This was a retrospective study including almost 600 patients, and 150 were treated with budesonide. They ended up including 380 patients in the analysis. They excluded anyone with cirrhosis, acute severe AIH. All the patients had to be treated with azathioprine. Ultimately, they compared 276 patients who received the budesonide, 276 prednisone, 105 budesonide. They did a weighted propensity matching score. And so their conclusions are that in Spain, at least, the use of budesonide as first-line treatment is low, and they found that it was usually prescribed to patients with lower transaminases at presentation, but overall, their conclusion was that budesonide was inferior. But I think time will tell as more studies come out. This next paper was published in Hepatology also within the last year or two, from the International Autoimmune Hepatitis Group, using their retrospective registry, and showed that lack of complete biochemical response at 6 months is associated with liver-related adverse outcomes. So again, going back to clinical endpoints and prognosis for hard outcomes in patients with AIH, this study included over 2,500 patients with AIH from multiple centers in multiple countries. And you can see here in these survival curves, the patients not reaching a complete biochemical response, so not having normal AST, ALT, and IgG after 6 months of therapy, had worse survival. And this was an important finding because their retrospective registry could be used for multiple other studies to answer other questions. And they found that in addition to lack of CBR, complete biochemical response, non-white ethnicity, and this is predominantly European centers, non-white ethnicity was significantly associated with liver-related death and transplant, as well as cirrhosis, which we have seen in multiple other studies, and cases of AIH overlapping with primary sclerosing cholangitis, all were independently associated with poor outcomes. Furthermore, they found that lack of CBR was associated with the development of cirrhosis during follow-up, so progression of fibrosis. Okay, so now let's talk a little bit about the research that we've been involved in at UCSF. This is one of our earlier studies where we found that autoimmune hepatitis disproportionately affects people of color at our hospital and in our hospital system. When I first joined the faculty in 2013, Jackie Maher knew that I was interested in autoimmune hepatitis and said, Michele, you could come and take care of the AIH patients in our ZSFG, at that point, SFGH liver clinic. We have a lot of Latina women whom we follow for their AIH. And so we looked a little bit more at the data behind this. We compared the racial ethnic composition of patients with AIH to a large number of matched controls from the San Francisco Health Network that feeds into our hospital for specialty care. And on multivariable analysis, we did find that a diagnosis of AIH was significantly associated with non-white race and ethnicity, so being Black, Latinx, Asian American, or other. We then went on to ask if this finding would hold up outside of San Francisco. And so we used the national inpatient sample to look at hospitalizations across the United States. And we did find that Black and Latinx Americans are hospitalized for AIH at a higher rate than their counterparts of other races and ethnicities. So you can see here, again, the breakdown of hospitalizations for AIH predominantly or disproportionately affecting Black and Latinx Americans. And then furthermore, the NIS has data on mortality during these hospitalizations. And when we did a multivariable model controlling for age, gender, payer, et cetera, the patients who died during a hospitalization for AIH had a higher odds of being Black or African American. And so these, of course, are very upsetting findings and beg the question, why do these disparities exist? But one major barrier to answering this question is that we don't really know what causes AIH. So we embarked on a pilot study funded by the ASLD in collaboration with the Chan Zuckerberg Biohub and Indiana University, where we did bulk RNA-seq to look at transcriptomics in patients with AIH. You can see here the study workflow. Volunteers with AIH and who were healthy gave blood samples through the GRACE cohort at Indiana University. RNA was extracted, sequenced, and then through bioinformatics, we looked at which genes were differentially expressed in the patients with disease versus healthy. These are the top 1,000 most highly expressed genes, and then it's a heat map with different clinical variables. Global gene expression did not vary by sex, and there were many hundreds of significantly differentially expressed genes. And some of the highlights of our findings were upregulation of innate immune pathways like interferon signaling in the patients with autoimmune hepatitis. And also 5 of the AIH samples surprisingly reveal sequences from a virus called Peggy virus, which is somewhat similar to hepatitis C virus. It was found in one of the healthy controls, but this was an intriguing finding, especially along with the interferon innate immune pathway signaling finding, potentially implicating a viral trigger for AIH in some patients. And that transcriptomics pilot motivated us to develop our own cohort study at UCSF. Prospective observational study to understand liver diseases was launched in 2018. Our thinking was that we wanted to study disparities in AIH, so we needed to recruit the vulnerable affected populations that we've seen have worse outcomes in prior studies. So for POSSLed, we are enrolling participants with autoimmune hepatitis and different comparator groups, and doing periodic assessments, including the collection of clinical data, biospecimens, and questionnaire data, and then following them for outcomes such as response to therapy, fibrosis progression, decompensation, transplant, and death. This is our website if you want to take a look. And POSSLed has been a rich resource for asking many different questions. One of the major questions we've been trying to answer is, what is the autoantigen in type 1 AIH? This is Arielle Klepper. She is junior faculty at UCSF now, but started working on this AIH translational work as a resident. And phage immunoprecipitation sequencing, or FIPSeq, is a platform in the Derisi lab and the BioHub, which involves a phage library displaying all the human peptides from the human proteome. And the phage library can be incubated with patient sera. So for this study, which was funded by the UCSF Liver Center and the NIH, NIDDK, we collaborated with UKE, the Hamburg group in Germany, and Frailty, another cohort here at UCSF with Jen Lai, and then included patients with AIH, PBC, and then NAFLD, now MASLD, and then using the immunoprecipitation, pulling down phage that were bound by antibodies. The bound phage are sequenced and aligned with the human genome to then determine which peptides the patient's sera are reactive to. And so FIPSeq did identify multiple antigens, both novel and established in AIH. There was substantial heterogeneity in the autoreactivity profiles of the individual AIH patients, as shown by this AUROC curve. It did very well when including all the peptides, but its predictive power was degraded when we tried to limit the number of peptides in the model. And here's okay, I'm running out of time, so I'll go a little bit faster. A heat map of the peptide hits in AIH, and relaxin family peptide receptor 1 is RXFP1. So that's a novel finding, not previously described in AIH. But also here you can see SLA peptide, which is one of the known autoantibodies used sometimes in the workup for AIH. And this diagram shows some of the beautiful functional studies that Arielle did to follow up the FIPSeq finding of RXFP1. What she found was that serum from AIH patients with anti-RXFP1 activity inhibited signaling in a functional assay in a cell culture model, and that this inhibition was in an IgG-dependent manner. And then here you can see the structure of the protein and the target of the autoantibody, which is extracellular, again, making it more plausible that it could have a role in AIH pathogenesis for certain patients. Another hit from FIP-seq was disco interacting protein 2 homolog A, or DIP2A. While it was a small number of patients who had autoreactivity to DIP2A, those autoantibodies cross-reacted with a virus, human herpes virus 6, specifically the U27 protein. And so you can see that protein structure here, and that homology was found using BLAST, and then through further phaser experiments, Ariel was able to test the exact peptides involved in the reactivity. So again, maybe implicating viruses in AIH idiopathogenesis. And POSSLD has also allowed us to collaborate with people like Bruce Wang. This was a study funded by the Chan Zuckerberg Initiative, where we sought to dissect inflammation in liver diseases, both in mice and in POSSLD participants, using single nucleus RNA sequencing. And so we performed single nucleus RNA sequencing on biopsies from POSSLD participants with AIH. And this UMAP shows that all major liver cell types were identified in patients with AIH and healthy control liver samples. The AIH livers had an expansion of NK, NKT, and T cells here in orange compared to healthy. And CD40 was a gene that found to be upregulated in AIH livers. And its ligand, CD40 ligand, was found to be upregulated in the NK, NKT cell population, whereas the CD40 gene was upregulated in B cells in AIH livers. And then furthermore, there's a co-receptor, CD28 or CTLA4, found on T cells, and CD80 on B cells. And the single nucleus RNA sequencing showed that CD40 and CD80 were both upregulated on B cells from the AIH liver biopsies. So this is a novel finding because CD40 and CD40 ligand have been found to be important in multiple other autoimmune diseases, and CD40 ligand is targetable by drugs. So this is an interesting potential way of treating, theoretically in the future with many more validation studies, could be a specific mechanism that could be targeted by medications, which would be a major advance since currently we're still using very non-specific medications like corticosteroids for the treatment of AIH. And so we are planning further experiments to investigate some of these findings in a project with the UCSF collabs and ImmunoX. You can see we're planning different experiments here, spatial transcriptomics, immunofluorescence microscopy, and site-seq. And then social determinants of health are a major factor in any health equity issue, but has not been evaluated in AIH. So we have paired with the European Reference Network and the Autoimmune Hepatitis Association. Irina Adow just graduated from UCSF Medical School and has been leading a project where we use a questionnaire about various domains of social determinants to learn more about the interaction of these biologic mechanisms and environmental factors in disparities in AIH. And so far, these are our preliminary data. The composite SDOH scores did not differ significantly between people with and without AIH. But among patients with AIH, a higher or less favorable SDOH score was linked with cirrhosis, as reported by the patients. And then in another model, including the major SDOH domains, discrimination, major experiences of discrimination, and then education level were also significantly associated with cirrhosis. And then finally, we are lacking a network study in AIH in America. And so multiple centers have come together to form a North American Alliance for AIH, which will be a forum for collaboration. And our first study is going to be a glimpse of AIH in North America, where we're going to sample cases diagnosed at our centers. We already have 30 plus centers participating, so stay tuned for more from the Alliance. And I'd like to end with acknowledgements, thanking everyone who's been involved in this work, particularly our patients and our sponsors, and the multiple faculty and trainees who have contributed and supported all of this research. Thank you so much for your attention.